Now, Dr. Parveen Rewri
Dr. Parveen.
to talk for SLT.
Good evening. Thank you, Ajanta team, Dr. Rajul and Shifali for this opportunity. Uh, I'm not here to oppose. I'm here to rationalize the things and to see whether the evidence-based things are there to support that SLT should be used as a first therapy in the mild to moderate cases. SLT is an outpatient procedures. It is the convenient and expected pressure reduction is 20 to 30% what we get from the first line drug therapy. It is effective in variety of glaucomas, open angle glaucomas, both primary, secondary, as well as the ocular hypertensions. It is repeatable and it doesn't require any strict post-operative regimes. Simply, if you can use NaCIDs or even no drug, it also works. It can be repeated, and in some patients, nearly in 50% patients, after 5 years, a repeat may be required. The light trials has proved beyond any doubt that SLT is not inferior to the drug therapy. In many ways, it is superior. It is achieving target IOP in 70% patients. Remember, the drug group achieved the target pressure in 93%, but 35% people required more than one drug to achieve their target pressures. The disease progression, faster disease progressions, the trabeculectomy number required, the cataract surgery required were lesser for the SLT than compared to the anti-glaucoma drugs. The meta-analyses have shown that better intraocular pressure reductions, reduced medications, and the cost effectiveness is better for the SLT than compared with the medicines. The quality of life for both the groups has been found to be almost equally for SLT and the medication groups. So definitely SLT has got certain advantages over the medications. Coming to the safety profiles, the SLT has very rarely has got any serious or complicating complications. Most of the complications are very mild discomfort and inflammations and a temporary rise of intraocular pressures. Post comparison in the Indian scenario, if we see the drugs have required the monthly recurring expenses, multiple visits, and the compliance issues are there. And a cost of therapy is nearly 2.5 lakhs to 6 lakhs for the lifetime per eye in the glaucoma medications. Compared to that, the SLT, which is a one-time procedure, reduces the medication uses, fewer follow-ups, and longer-term savings cost from 8,000 to 50,000 for a patient for the lifetime. So it's much less costlier. So SLT becomes economically favorable for the patient in the long run. Experience with the Indian patients, though there are very limited studies has published, but all this have shown that the pressure reductions for the SLT is nearly 30% for the Indian patients. The Indian challenges to the glaucoma therapies are already Maya has put up. There are poor follow-ups, contrast sensitivities, rural access, elderly populations, and medical compliance are there. So SLT can address all of these issues because it is a one-time procedure and can handle all these compliance and the direct therapy-related issues for the patients of Indian origin. Why SLT for Indian patient as the first therapy? Because of the favorable biology. We know all that the higher the melanin content of the cells, the better absorption will be there. So we have the dark trabecular meshwork, so better absorption will suit us. Similarly, will overcome the compliance issues and we have a better affordability as we have seen the previous slides. The guidelines from all across the world shows that SLT is being adopted as the first line treatment now for the mild to moderate glaucoma, and the global trend is now moving towards SLT being the first management for the open angle glaucomas. Therapy is the future. We are almost doing the same debate what we were doing when the PI was introduced. We were thinking and we are talking about a lot whether it will surpass the effect of pilocarpine or not. And the time has tell what the evolution has been that YAG PI is now the standard treatment for our angle closures. I think the time will come when SLT will become the first treatment for the mild to moderate glaucomas in the open angles. So in my conclusions, being an evidence-based, safe, repeatable, which reduces medication burden, improves adherence, and is cost-effective, and is going to fit the Indian patients, SLT will be my first choice for mild to moderate glaucoma in Indian patients. Thank you for patience hearing.
So thank you, Dr. Avery. I will invite Dr. Sneha, who is on our expert panel. And we have around 10 minutes for our discussion. So Dr. Rita, Dr. Chandrima, and Dr. Sneha. So I think we already discussed about SLT. So my question would be, since light trial, this promoting SLT as a first line of treatment. So I will just, my question is that how have you incorporated this SLT or the results of light trial in your practice? How many patients you are doing in your practice? How do you choose your patients for SLT versus medication? Yeah, Dr. Rita.
I've been using SLT for a long, long time now, and I think it works beautifully as a primary treatment. But being in practice, you're not the first person who's seeing the patient. So patients come already on medication, and patients who are treatment naive do much better than patients who have already been on medication, especially if they've been on prostaglandins. Then the way to go about is to stop the prostaglandins because you have to have a washout period, and only then do the SLT. The second thing I would really, really like to, agree with is compliance is a big issue with the medications, which we all know. I mean, it's a very well-known fact. You can't think about it. Cost is something that doesn't apply at all because you know that SLT is going to act only for few years. It's not going to act for a long time. So, you pay that cost that will cover probably the amount of medication the patient will have to put in, but he's not going to put in as
Do you consider staging of the disease also?
Absolutely. So, especially in the early, first mild to moderate glaucomas, I would always start with an SLT, but I would make him understand that this is not permanent treatment. He has to continue to do the follow up because we have to continue to see when the SLT is going to be on the wane and when we'll need to, add up to treatment.
So how many weeks like you wait before you go on to say that, do you do both the eyes in the first sitting or you wait before you go on to do the?
No, I do both the eyes at the same sitting. I wait. I take the pressures post SLT. 3 hours later, I make the patient wait, see how much is the spike, but don't give them any anti-inflammatory agents. I don't give them any steroids. I wait for the action to come on. There will be a little spike, and that can be covered with oral carbonic anhydrase inhibitors. Just tide over that time, and after that, in 2 to 3 weeks, you see that the action of the SLT is maximal, and it stays like that for at least 2 years.
How much percentage of the IOP reduction you
So you
feel
get
that
about
it is?
30% of IOP reduction if you're treating a treatment naive patient. If you have a patient who's been on medication, especially prostaglandins, and even if you stop them, then the pressure decline is about 25%.
So basically, it should be more than 30% IOP reduction from the baseline. That is what you expect before you say,
Correct.
going to say that it is a successful.
Absolutely.
So suppose if the patient, if the pressure rises within 4 to 6 months, do you repeat SLT or would you shift the
No, no,
patient
no.
to
If the
medication?
pressure rises within 4 to 6 months, I haven't seen that happen truly. I think there's inadequate SLT done or whatever, but you always see that the pressure remains low at least 100% of the times for at least 18 months to 24 months. Quite often, I've done a repeat SLT 3 years after the first SLT.
Okay, light trial, the success rate is nearly 70%. Anyway, it is any other opinion?
Uh, yes, so even I agree. My first line of treatment would be for POAG or ocular hypertensive. I would offer, and I believe why not? We should offer SLT. Uh, uh, I would also add to your, I mean, whatever you've said, madam, that also higher IOPs, the results are better
Better.
and more with the pigmentary glaucomas and this, yes, pseudo exfoliations, we've seen a better result. But, madam, I've repeated as early as I have a couple of cases as early as 1 year. I have repeated so most of the cases they are under control. But again, I've tried it only in treatment naive eyes, like not the ones who've been on long-term therapy. I have seen it doesn't work that well.
When do you decide that this patient is now the right candidate or right time for re-SLT? What is the time period that you decide?
I have done it as early as 1 year, but if the patient tells me no, okay, let's start drops, and if the patient is not comfortable, uh, then I would move on to the drops. So this discussion I do have with the patient. If they're like they don't want to try again, then I would move on to the medications.
Any other opinion?
Well, I'm not a great proponent of SLT. With my limited experience of SLT, I would say that you need a treatment naive patient. And even when you do it on a treatment naive patient, you have to wait for at least 2 months before the IOP lowering is substantial. In that time, you would add anti-glaucoma medications to it. I would actually use SLT for an interim period, say like pregnancy. That's where I would advise the patient SLT and take the patient off drugs. Lactation. These are phases where I would like to use SLT, not on a regular patient. Maybe as of now, I agree to disagree.
Okay. So now I think one of the hot topic is whether to do the lens extraction in PACD patient or not. So I would like to have expert opinion. Which patients you will write from bang on, you will say this patient is for phacotrap or for the combined surgery. Now since mix is also there, it has definitely changed our whole scenario, only spectrum of our management. So which are the patient you will choose directly rather than phaco only? No, this is my patient for combined surgery. Which patients?
Uh, for combined surgery, basically, I would reserve combined surgery for those patients. Like, if you're doing it, let's divide it into, say, primary open angle glaucoma and angle closure disease. Primary open angle glaucoma, well, if the patient is on 3 or more drugs.
I'm talking only of angle closure disease,
Angle
not of
closure.
open angle.
Okay, so if you go for angle closure disease, in that case, a lot of factors matter because it depends on what was the range of IOP preoperatively, whether the patient has been on maximum medication preoperatively. Again, if a patient has been on maximum medication for a short period of time because the glaucoma was detected later, that is again different from a patient who has been on maximum medication for a longer period of time. So, all these factors would come into play before I decide on a phacotrabeculectomy. And I definitely see the height of the lens vault, what is the anterior chamber depth. These are very important factors. Otherwise, you could really mess up a phacotrabeculectomy and the patient could lose vision more than what it was preoperative.
Would you consider synechiae, amount of synechiae?
Absolutely, absolutely. A very good gonioscopy is absolutely mandatory before you decide on doing a phacotrab, because you have to see the extent to which the angle is open, on indentation, what is the angle like, and how much of pass is there in the angle. All these factors are very, very important.
So I think she has summarized, but just last question. So what is the cutoff of the lens vault? Since you talked about lens vaults, what is the cutoff value that you take for the
If
lens
you
vault?
use a particular value,
And suppose if you do not have ASOCT in your clinic, then how will you decide whether this patient will need only cataract or
so if you don't
combined
have an ASOCT, it's very simple. You're going to do the A scan anyway. So you can also measure the lens thickness.
thickness?
And if the lens thickness is 5 millimeters, 5
Mm.
or more, then you will definitely think that this is a forward vaulting lens, and you would definitely not you want to get that lens off.
Yes, yes. And if there is a progressive shallowing of the anterior chamber when you are following up the patients, convex type of iris where AC is very shallow, or if the distance anterior chamber is very shallow, less than 1.9 to 2 millimeters. So these are the patients where if you do only cataract surgery, pressure in PACD patients. So there's definitely they will have reduction in the intraocular pressure also. So I think
I
our
think
time is off, and we
just one thing to add, ma'am.
yeah,
Looking at all these parameters, the patients who would actually fall into the category of combined surgery would be very smaller amount as compared to what we debate in a larger perspective. So that is to be not every glaucoma patient you jump into combined. That's what I want to kind of
agree,
get into this.
agree.